Welcome to Cyber Survivor. I'm your host, Dan Dodson. And today I'm sitting down with Dr. Kruse, who recently, or I should say about 8.5 years ago, wrote an article about healthcare, IT, and security titled Cybersecurity in Healthcare, a Systematic Review of Modern Threats and Trends. And so I'm very interested to sit down with him today and talk about that paper and certainly what's changed over the years. And so Dr. Kruse, welcome to the show.
Thank you very much.
So I want to start by saying, how did you get into academic right now? Obviously, you're the Dean of Health Sciences at the University of Texas in El Paso. I would love to hear a little bit of background on how you got into doing that.
All right. So my IT background is from the military and from formal education. So I spent 25 years in the Army. I spent time in the Army Medical Service Corps, and I was trained to set up hospitals and manage their networks, both fixed and deployed hospitals. And that was a specialist concentration. And then I became more of a generalist and became a healthcare administrator. And after I started pursuing my PhD, the more I pursued the master's degrees, I kind of liked it. And because I was doing the specialist track of the computer geek, the computer nerd for the hospitals. The Army wanted to send me to more and more geek schools. And so I got to have an MBA and then later a Master's of Science in Information Technology. And then I also had a Master's in Healthcare Administration. That was the generalist portion of it. And then worked in fixed facilities and worked in deployed facilities and was really liking it, but I liked the education part pretty more than the other things. And so I decided to go and pursue my PhD, and I was smart the way I did it. I asked the VA to pay for it rather than the Army to pay for it, because if the Army was going to pay for it, there was going to be a commitment. And I had already been deployed more than I wanted to be deployed. And so when my number came up to go to Afghanistan with the 82nd Airborne, I said, no, thank you. And so I was able to finish my PhD and then got hired on by Texas State University. And so taught, I've been in higher academia ever since. And so I've been in academia now for 18 years, and kind of liking it. I really enjoy the challenge. There's still leadership opportunities, particularly in a position like I'm in now. I was an administrator at my previous employer, which was Texas State University, and I'm an administrator here as well. And so I still get to exercise the leadership portion of my background because I graduated from West Point and was a small unit leader, like platoon leader, company commander. Then I served in the large staff positions, and then started doing the academe thing. So I really enjoy that portion of it. But what's interesting is there aren't really many people that publish in cybersecurity of healthcare. And I've actually published 2 papers on it, and I've got a third that's under consideration now. I've got about a little over 70 publications total, and the focus of my research looks at the adoption of health information technology, and I look specifically in the clinical side, the differences in health outcomes between using the technology and then using the traditional standard of care. And so typically it's without technology. And by and large, I've found that the with technology has shown positive health outcomes as a result of that decision to adopt it. In fact, I published a paper specifically showing health information technology shows positive health outcomes, just highlighting that all the work that I've done so far is really showing a very good light on technology. But then the dark side of it is cybersecurity, and we are an attack, a target of attack. Because the target of healthcare is even more lucrative than banking, and it's more lucrative because it can be sold over and over and over again on the black market. So it's whereas a person's identity can be sold once on the black market and then it's shut down, they estimate it can be sold about 10 different times when it's on the healthcare side, and so the damage is so much greater. So there aren't really a whole lot of folks that publish in that space, mostly because there isn't a requirement to report. There's only a requirement to report if the personal identity of the patients has been violated. So the other things aren't reported. There's innocuous attacks, and then there are really, really bad attacks that can be devastating to a hospital or a healthcare system. So I am just one of the folks that got identified pretty early on for publishing in this space. So I was identified a couple of years ago by CMS, a guy named Bill Urich, and he works out of CMS, and he also published in the space of cybersecurity and healthcare. So he asked me if I'd help him set up a workshop for cybersecurity and healthcare specific to the U.S. So for the last 2 years, we've been setting up these workshops. They've been really neat. We just finished one out in Honolulu. I didn't argue at all that it was in Honolulu in December. I think I snapped my finger and said, "Oh, shucks, let's go for it."
Yeah, I think a trip to Honolulu would certainly be fun. Absolutely. Well, first of all, Dr. Kruse, thank you so much for the service that you had for our country. I am a huge fan of veterans. We employ a lot at Fortified, and I'm grateful for that. And your continued service in helping us better understand how to tackle and protect patients and communities across the country as it relates to cybersecurity. So just thank you. I want to start with that.
Very welcome. We couldn't do the service without the support.
Yeah, absolutely. When you think about your research and you're thinking about, I love the fact that you've done research proving that technology has increased and produced better outcomes, right? Because, in the healthcare IT space, which is a lot of our listeners in the cyberspace, there's this conversation around, we really digitized healthcare and high tech, and we run hundreds of systems. And to your point, it is awesome on one sense, but then it opens us up for cyber attacks as well. But it's good to know that the research has proven that the investments that we're making and thus the risks that we're making is producing better outcomes. How have you seen cybersecurity kind of morph and mature and transform from your earlier research on, some of the statistics around spending 95% of their budget implementations and running the IT and only 5% on cyber? I mean, how have you seen some of those balances change over the last number of years?
So AI has taken on a real big player in the cybersecurity space because it can be used by both sides. It can be used as an attacker or as a defender. And so then it gets into whose AI is stronger. And that gets into the prompts and being able to be familiar with AI, being able to structure a set of questions for AI to grab onto and run with it without the hallucinations. So we're using cybersecurity right now. We're using AI quite a bit in cybersecurity. We're looking at using it as both an active and a passive means of defending the network and the infrastructure. And so AI is by far the biggest change that has occurred in the last 10 years.
Yeah, and do you think that healthcare organizations have, allocated the appropriate amount of capital to cybersecurity? One of the challenges is that, across the U.S., as I know you're familiar with, these organizations are operating on grocery store margin budgets. Every dollar we move to IT is a dollar away from the bedside. How have you seen that change over the years?
Well, I was a deputy CIO of a hospital in Virginia many years ago. And that was actually a point of contention with our CFO. The CFO, we're vying for dollars every year. And I'm an expensive part of the hospital's operation. And so, we'd walk into the briefs with the CEO, the president of the hospital. And I'd say, okay, I've briefed this to the COO. This is what I'm asking. And I'd be asking for some real expensive tools. And I'd be asking for a pretty big paycheck, pretty big blank check for training for my specialists on my team. And the CFO was just the poor guy. I was giving him conniptions. And he was saying, I just paid for security last year. Why do I have to pay for it this year? Well, that's a big misconception. And so there has to be a lot of education to answer that question. And then he was saying, so you're saying I spend all this money and we never see an outcome because we prevented all these attacks. And I said, yep, that's absolutely correct. And he said, so if I spend all this money today, our hospital is secure? And I said, absolutely not. I would never make that strong of a statement. My job is not to secure the hospital. My job is to make it so difficult and so challenging to the attackers when they attack my network that they seek a softer target. I could never say that we are immune to attack. We are attacked every day. So it becomes a lot of education that goes into why we have to spend the money that we do. And then it's really difficult to make those cases that we need the big paychecks. Training was a big thing that I was always real interested in. I wanted to make sure that my folks had access to current training to make sure that our network, we had a better chance of securing our infrastructure. And folks were, in fact, I worked for the COO, and he was going, you asked for this money last year, and everybody who got the training got a higher paying job in another hospital. And I said, yep, I'm proud to say that's one of our legacies. And he said, so we're just going to train these people to have them go elsewhere? And I said, well, I mean, we're also building our brand with the community. These are now assets that we have. They are great relationships that we have with other hospitals. And so I'm able to pick up the phone and call John, call Ted, and say, hey, what are you all seeing in this scope? And they're not inhibited to tell me the truth. So yeah, there's a lot that goes into where we're spending the money to secure the hospital, to secure the infrastructure. And the whole idea is keeping the patient's data safe, because patient data is one of the highest target assets the hospital has.
Yeah, no doubt. And in the last couple of years, too, we've seen a lot of clinical disruption, right? We've seen large downtimes where we're, delaying care or diverting care. And so as you think about your research around, hey, this technology is providing better outcomes, and yet if you find yourself in the middle of a breach or you're down, you can't provide those good outcomes, we become so reliant on it. How do you balance the notion of both of those at the same time?
Yeah, I mean, it's a delicate dance. The CEOs, the CIOs today have a big challenge in that scope. And there's there's a technology leapfrog that takes place. And, once we find out of a good defense tool, the attackers find it and they exploit that defense tool. So there's constantly that leapfrog that goes on. Right now, for the last, 20, 30 years, the open source stuff has been out there, and there's two really big sides of that coin on the open source. Some feel like, well, with open source, we get all the advantages. We can get all these creative minds to contribute, and the other side of that coin is you get all the nefarious minds that now have access to your code, and so that's just part of that leapfrog that's taking place. And I think predominantly the side of the coin that is winning is the open source. That the more we have it available to creative minds, the better we can secure it. In fact, that was we just finished, like I mentioned, with our HealthSec workshop last week in Honolulu, and we talked about that quite a bit. And we talked about SBOMs, which is software bill of materials. And the software bill of materials is an open source effort. It's actually required by the FDA for devices, so that people, when they're adopting a device, understand all the vulnerabilities that come with that device. And so the idea is you publish this and you can better defend those devices. Well, the other side of that is now you're also advertising all the vulnerabilities to the folks that want to attack hospitals with that device. And we talked about that at length in our workshop. We had two people who published on diabetes, and we have all these great devices now that are constantly monitoring blood sugar. And you can either have it automatically introduce glucose to the blood, or you can have, or the insulin, or you can, you just see the readings and then you adjust it based on your activity level. And so a lot of folks are saying, why haven't those been attacked? Because the vulnerabilities have been out there for years. Well, I mean, from my perspective, the answer to that question is very easy, because there's no money in it. You can't tell the hospital, I'm going to exploit all of your diabetes devices. The hospital would say, I don't own those devices. We simply, we're simply the middleman to introduce those to our patients. But if you shut them down, we'll just go to another product. I mean, it's not that big of a deal. It's when the ransomware stuff comes in and they lock down the entire electronic medical record. They essentially encrypt it, and they say, we're not going to give you the cipher for this encryption without a certain amount of money being paid. And that's where the big money comes in.
Yeah, no, you touch on something that's very important, I think, for everyone to understand, is that the adversarial intent as to why they're doing these attacks is because they want money. You know, to your point, that's what they're after. And so that's why these large health systems who are so reliant on this technology oftentimes find themselves in the crosshairs, as you mentioned. Talk to me a little bit about these summits. I'm interested. What are these summits all about, and who gets to go, and what do they look like?
So it's a workshop. We tag on to an existing a conference, a geek conference. So this last one was ACSAC. I constantly have to look that one up. It's annual Computer Security Applications Conference, and so they're the ones that had their conference in Honolulu, and then next year I think they're having their conference in LA. But the whole idea was we don't have the resources to establish an entire conference. We just need to do a one-day workshop. Now, it's a long day, but it's a one-day workshop. And so right now we are beginning to plan next year's workshop. And so what we do is we do a request for papers. And we have a group of peer reviewers that go through those papers and provide a peer review. And those that are at the publication level, we're able to get these published through IEEE. And so that's the whole idea, is they come to this conference and they present these papers. And so it's a whole room full of cybersecurity geeks, and specifically in the healthcare space. And we're able to share ideas and have some discussions. And there were, 6 different papers on SBOMs this last year. So SBOMs were a really big topic, or at least one that raised the level of publication level of products. And so they'll be published in the IEEE Explore website in the next, month, I think, when they'll all be published. And so I'm just one of the organizers for it, and I manage at least one of the paper sessions. In fact, Bill was having trouble getting folks to come up on the net and say they would do it. So I said, just put me down for all of them. I can manage the schedule as well as the next person. And then he had a couple other folks say they would manage a session. So we had 4 paper sessions, and we went from 8 o'clock till almost 6 that night. And because we're tagging onto an existing conference, then we're able to get the economies of scale and get their pricing for the rooms and for the catering. And so it works out really well. In the summer of 24 was our first one, and that one was in Salt Lake City. But that conference moved to Taiwan for this year. And if we went to Taiwan, it would prevent grad students from traveling and presenting. And that's not what we're trying to do. We're trying to enable them to come and present their work and get the advantages of that workshop environment.
Got it. And when these papers become published, I'm sure it varies from paper to paper, but what is the desired outcome that the authors want? To raise awareness, to drive different regulations? Like, what typically is the why behind the creation of this research?
So, of course, that is absolutely part of academia in general, is to create a sense of economic advantage to the U.S. That's why the National Science Foundation funds research. That's one of the focus areas, is to enable some sort of economic advantage to the United States. And so the sharing of ideas is part of why you would publish a paper. Influencing policy is one of the reasons you would publish a paper. Providing tools or new knowledge to practitioners in the field is an area. And then every once in a while you come across something where there's intellectual property possibilities. it's difficult to have in the cyberspace because algorithms, there isn't anything copyrightable in algorithms, because people can just change a couple of numbers. It's significant difference. The patent office would issue a new patent, or they would say it's not really worth the money for a patent. But the idea, though, in that sharing of knowledge is building your own brand. It's the sharing of ideas with other academe, and then it's also being able to affect or change public policy, and then just every once in a while you come together and one person knows one thing, one person knows another, and the two together are an incredible solution. And so that workshop environment can be very powerful.
Yeah, absolutely. Well, there's no doubt we need more collaboration as we continue to fight these adversaries. But you mentioned something of interest to me. So thinking about the public policy angle, there's a lot of discussions around, creating a minimal cyber standard, adjusting the HIPAA regulations. There's conversations about some type of funding mechanism, which I think is going to be difficult in the current political climate that we live in. How do you think about what positive outcomes could happen on the public policy front?
So the EU, they came out with the Cyber Resiliency Act fairly recently. I don't think it goes into full implementation until 2027, but that really puts them ahead of the U.S. in that regard. They came up with some very basic standards for cyber resiliency, and there's even cyber resiliency standards now that are published that you're able to get to your hospital, like ISO. ISO isn't really required in the U.S., but it's kind of nice to have if somebody has an ISO 9001. So in the U.S., what I could see us doing is actually adopting some of the standards in the EU Cyber Resiliency Act that would place our hospitals at an advantage. So what's really interesting is when you look at their Cyber Resilience Act, there's a lot of really common sense stuff that's in the Cyber Resilience Act, and then there's stuff that's just no-brainers. But there are things that our hospitals in our country are failing at. When somebody says, make sure you update your software. I mean, any computer geek worth their salt would say, of course I want to update my software. But there are constantly folks that are getting their network hacked because they haven't done that very simple thing. Storing your tapes, your backup tapes off-site is a very standard practice. Some folks aren't doing it. And so there's all these really basic standards that are part of every computer nerd's training. When I went through my MCSE back in late 90s, early 2000s, it's some really good information. I never intended to be a network engineer. I mostly wanted to be that paper tiger so I could tell when my network engineers weren't telling me the right stuff, which was very helpful in that regard. But what I'm finding, though, is in some of the exploits that I've seen in our country, they're not following that very basic training that has been taught for 30 years. So I would say if we adopted a lot of the standards from the EU's Cyber Resilience Act, that would be very helpful.
But do you think that part of the lack of adoption in the U.S., especially in the healthcare realm, is due to capital more so than knowledge?
It absolutely is. I mean, every year, every CFO of a hospital is looking at where is the best way to spend this money. And the CFO is telling the COO and the CEO, here's where I think we can spend it. And the CIO is going, whoa, hey, what about this guy? I have some very necessary stuff as well. And so there's this constant push and pull. The problem is, though, is if you have a bad actor come in and encrypt the entire electronic health record, now you can't do anything. So it is really it's a challenge. So until the public policy says it's required or certain standards required, then the CFO is going to be able to listen to all the other arguments or give them equal weight to what the CIO is saying.
Yeah, and I think you're right. And I think that in my experience, at least, kind of what moves capital in healthcare is, patient quality, revenue and regulation, right? And depending on the season at the organization, one might be 1, 2, or 3. But even if we get the regulation right, is there going to be enough capital there to actually implement some of these standards, which I think is a great debate. I mean, how do you feel about that?
Well, I completely agree. What part are you asking for a debate on?
No, do you think that there needs to be a funding mechanism? Like if there was a minimum standard created, does there also need to be some type of meaningful use like mechanism? There's flaws with that for sure, to help, provide capital, quite frankly, to the organizations that need it to be able to actually implement the standards.
No, I don't think it needs to be publicly funded. So, I mean, hospitals already, healthcare in general is a highly regulated business. And if the policymakers set a national standard for a floor minimum, the hospitals would find the money. They would allocate the existing resources to the point where they would meet that standard. I don't perceive that it would put anyone under. Like I think Ascension is a great example. In 2024, Ascension in Birmingham finally went bankrupt because they refused to pay the ransom to negative actors when they came in and encrypted their electronic health record. And it was absolutely the right stand, and that's what the federal government says we should do: is don't reward the bad actors. Well, they absolutely didn't reward them to the point of bankruptcy. So, I mean, that's a problem. So that's where the federal government could step in, is coming in to better identify the bad actors and shut them down, or provide some resources, not money, but resources in terms of being able to decipher, find the cipher to unencrypt the electronic health record. So I mean, that's part of it. And then the other issue is, and I haven't read the whole story about Ascension. I just have my wife has cousins who worked in that system, so they were telling me from their side of it what they're experiencing. But chances are, had they been doing their regular backups and storing them off site, they could have recovered their entire electronic health record from the backups and only been lacking the data that had been entered since the last full backup. So to me, it says they weren't doing those basics cyber training. That goes into all of us, our geek training. So I think if the federal government could provide anything, it would be tools to go after the attackers, to shut them down, so that they're less likely to attack a target within the continental United States or even our outlying territories, or provide us some resource to help find ciphers. But I think some of those basic practices have to be reinforced. And that's where I think we set a baseline standard. So these are all recommendations, and in all the geek training we have, they say, if you do these things, you're less likely to get attacked. But they're not required. They're just recommended. Now, chances are, if they're not doing them and they got attacked, their person's going to be fired. So that's not helpful. But I guess maybe we make that a legal standard, then maybe they're more likely to meet it.
Yeah, I mean, I agree with you that the healthcare system at large is used to complying with different regulations that are requirements. I think recommendations often get pushed to the not right now pile for other competing priorities. Right. So that's a great distinction. Being in academia and seeing these students that are coming out, obviously in today's environment, highly reliant on technology. The physicians, clinicians that are coming out in their training, they are used to delivering care with these fantastic tools. And to your earlier comment, producing better outcomes for patients, which is why we all want to support that from an IT perspective. But if they're caught in a situation where they don't have those tools because of a downtime, I'm hearing from people that that's a real struggle. I mean, they don't know how to operate without these tools. I mean, how do you think about that as we're training the next generation of clinicians?
Yeah. A few years ago, I was working in a large medical system, and in the regular monthly check of the generator. So this is a monthly check. There's an announcement goes over the intercom. We will be testing the generator. You should see no disruption of resources. So we have this very careful system set up in place in the server rooms, where you got your servers that are the primaries and the backups. And then there's battery backups that are over against the wall that can keep everything going until the generator kicks on. And then the generator picks up and runs everything, all the necessary systems of the hospital, including all the servers and the electronic medical record. But what happened was there's a failover switch. The switch that sent everything to the generator failed. $20 switch failed. So now the battery backups could not sustain everything for very long at all. And then there were hard shutdowns of the entire server systems. That is bad. Hard shutdowns are bad for any server. And so it took us a week because we had to get the full backups from offsite. We were storing them offsite. We had to restore all those backups. And then we had to go in and then enter all the data that was missing from the time the backup was made until today. So the problem is that gap. That gap is where we needed to go back to paper. No one knew how to do paper. Nobody. No one had any idea the process for paper because we were so reliant on the electronic health record. So then that keyed in, okay, so we need to teach folks both processes that 99.99% of the time we're using the electronic medical record, but just in case that $20 switch doesn't do what it's supposed to do, then we're going to need to revert to paper. And you're exactly right. We've got to keep that skill alive. It is a challenge.
Yeah. And do you think that the healthcare system at large is more resilient today than it was when you first started looking at it?
Oh, absolutely. I mean, we're absolutely better at it than we used to be. I mean, I think probably goes without saying. However, it needs to continue because, like I said, we have that leapfrog, that technology leapfrog that's constantly out there. And so you have the white hackers, the gray hackers, and the black hat hackers, hackers. And we constantly have to be, the gray folks are in the middle, gray hats. And so we constantly have to be in touch with them to say, what is the latest? One of the challenges with the fact that the attacks aren't required to be reported is we don't know how we can get everybody else to defend against that particular attack. And so by publishing all attacks, at least we, number one, would be aware of the full scope of the problem in our country, but then also how do we defend against those? And so perhaps that's another area where public policy could come in, and that's some sort of a repository that of attacks, of exploits and defenses that we could have that are required for everyone to have in their systems. And I hate to use the word required because we're already a very highly regulated industry. However, we're also 10 times the value on the black market for exploits.
Yeah, for sure. I know you mentioned AI a little bit earlier, but what do you think the next set of challenges will be in healthcare cybersecurity?
So what we're seeing over the last year or so is we're using passive AI and active AI. So the passive AI is what is going on in the network that doesn't look like it should look. And then the active AI are the basically the packet sniffers. What is going on in each of the packets in real time that doesn't look normal? And so it's the intrusion detection system on steroids, and it can react much faster than a lot of the IDSs that are out there. The intrusion detection systems are specifically there to defend against the nefarious players. But the problem with the traditional IDS is it's only as good as its last software update, whereas the AI can constantly be monitoring what's going on in the cyberspace to see what is the newest thing that can be put on and be watched for. So I think that's why we're going to see more and more of that.
That's great. I know you said you had one paper that you're working on right now. Are you able to share a little bit about what that's about?
Yeah. So we looked at All of the cybersecurity exploits that have been published in the last 5 years. I think it was last 5 years. And so we had a pretty large number we could look at and evaluate. And so it was the exploits, it was the defenses, and we specifically look at what they're using to defend their network, to react against the intrusions, and to recover from those intrusions. And so we had that three-pronged aspect to the research. And so what we found is we identified all of the exploits and all the defenses, and then all of the recoveries. And then after we put all those together and categorized them, what we found is almost all of them were covered in the EU's Cyber Resilience Act. And so our conclusion was, if we just did that, we would be so much better off. And what was so funny is the first time I went through peer review through a journal, all the folks that responded said, "This is garbage. You're just categorizing it into one big bucket." But I'm not wrong. I mean, it's all there. It's all part of the Cyber Resilience Act. And so it got rejected by one journal. It's off with another journal now. So we'll see what this next round of reviewers have for it.
Yeah. So it sounds like you're a pretty big proponent of taking what the EU is doing and trying to figure out how we get that in place here in the U.S. Is that fair?
I'm a proponent for the EU's Cyber Resilience Act. I'm not sure I made that global statement of everything the EU is doing.
Thank you very much for that clarification. That was the question that I meant to ask. We don't have enough time to get into the entirety of the EU.
Definitely not.
With respect to the cyber resiliency, yes.
Right.
Okay. And what do you think the chances of that are? I mean, we follow public policy. We participate in the Healthcare Coordinating Council. We've talked in front of Congress. What's your view on the momentum there? I mean, are we any closer than we were?
So I think we are. When you look at the cycles that go into any presidential administration, we've passed the first 100 days. We're approaching the end of the first year, and so what's going on in that second year is preparing for the midterms. So history shows us that midterms typically flip the side of the strongest part of the majority party. And so it really just depends on what the priorities are going to be for that new regime that comes in after the midterms, because everyone's going to have their agenda. If the Republicans hold on to the majority, that's their strongest point to make change. If Democrats win the majority, they're going to want to undo a lot of the things that the Republicans have done, and so we get into this. It's a very frustrating loop to watch. So it all depends on what's going to happen with the midterms. I think that's really going to be the focus for this next year. So, I would love to think that things that I publish affect public policy. My locus of control isn't quite that high. However, I'm not above sending things to people that I think they should look at. So I would have no problem with that. But as far as the chances of it, I don't know. It's been a while since we've had, because we had the High-Tech Act in 2011. That's really the last time we've had a significant healthcare cybersecurity or healthcare security type of act passed. So we're certainly due for it. It would be nice to see it. And the fact that the EU had that theirs will go into effect in 2027, it still has some pretty good press on it right now. Maybe the administration might pay attention to it. I'm not sure.
Yeah. Well, even like HIPAA, right? They were looking at redoing HIPAA, and that was open for comment, and that seems to be stalled or delayed at best. And
what happened with HIPAA? So HIPAA came out in '96. It was fully in effect in 2003, and then High-Tech updated HIPAA in 2011, and so that you constantly get to the point where policy is only as good as when it was written, and technology is constantly outpacing it. But we have to update it at some point. We absolutely have to do it. We're never going to have something that's future trending. We at least have to secure the infrastructure today over all the exploits from today backwards. So I think we're certainly due.
Yeah, no, I would agree with that. It'll be interesting to see how it plays out over the next couple of years, and certainly think that creating a set of standards to help build resiliency across the country would be
Right.
something that would be welcomed for sure. Well, are there any other comments that you want to make around your prior research or research that you have coming down the pike?
Yeah, to any of the reviewers of my current paper, please pass my current paper under review. I'd love to have that thing published.
That's a great way to end it, Dr. Kruse. Really appreciate your time today. Thank you so much for coming on.
Thank you. I appreciate the opportunity.
Yep. I'm Dan Dodson, and this is Cyber Survivor.